What I'm going to talk about is the so far reported neurological complications in patients who've had COVID-19, which is now called SARS CoV-2 infection. And of note, although we've had Cerebell at my institution since 2019, and I do read them. I've been an enthusiastic fan of them, but I am not a hired consultant. I don't serve on any board for Cerebell. So as most of you probably know, there was a paper published online April 10th, 2020 in JAMA Neurology. And this came from 3 Wuhan hospitals of 214 COVID-19 positive patients who were admitted. And what they found was this was the breakdown of the symptoms. The majority of neurosymptoms reported occurred in a median of 2 days after they were admitted, usually 1 to 2 days. And notice the most common was dizziness, 17%, headache, 13%. Then this vague skeletal muscle injury, not necessarily myalgias for what it's worth. They weren't so specific. And that was 11%. Of interest, as you know, there's been some reports that maybe 30% of patients with mild COVID-19 infections might complain of anosmia, and some of them have dysgeusia, lack of taste. But in their series, this series, it was only 5% anosmia and dysgeusia 6%. Now, when they sifted through the data, they said that neurological symptoms were more common in patients who had severe infections. And as we know, severe infections of COVID-19 are more common in older patients, particularly those who have more comorbidities, and in this cohort, hypertension was a common comorbidity. Now, what they did say is that the neurologic symptoms were more common, and what did they find? Of the big 3, they found impaired consciousness, acute cerebrovascular, and skeletal muscle injury. So if you had a severe infection of COVID, you were more likely to present to have acute cerebrovascular disease compared to those who had mild to moderate. And impaired consciousness was like present in 15% of those with severe versus 2% who had mild to moderate. And skeletal muscle injury, 19% versus 5%. Now, of the strokes, of which there were only 6, 5 of them were ischemic. 1 was an intracerebral hemorrhage. For example, one patient presented with an acute hemiplegia, and the big party line was that the patient didn't have the typical COVID-19 symptoms, that is fever, dry mouth, anorexia, diarrhea, when they first presented with the hemiplegia. And then they got a CT scan and confirmed seeing these ground glass densities the next day. And again, this is this rhinorrhea. This is a discussion of anosmia. So there was a report, sudden onset of anosmia or dysgeusia occurred in 30% of patients with mild COVID-19. And the interesting issue is most of the time when adults complain of anosmia, they've got chronic rhinorrhea, nasal congestion. And the nuance on COVID-19 is they don't have nasal congestion by and large. They don't have rhinorrhea, and so it's the isolated presentation. Of course, there's concern because in animal models, mice of coronaviruses, access to the infection is often via the olfactory epithelium. More on that later. But the party line was don't give corticosteroids when somebody presents with anosmia and dysgeusia without rhinorrhea, because that might worsen the COVID-19. And if you do develop anosmia acutely, you should test for COVID-19 or at least self-isolate for 7 days. Now, the second big paper that's came out from the University of Strasbourg, and here's a picture of the doorway there. And basically, there were 64 consecutive COVID-19 patients who were hospitalized in their ICU. And they had ARDS, and they were sedated for that. And they had data on 58 patients. Well, what did they find? First of all, 14% were agitated when they were admitted to the ICU. 67% acted agitated after their sedation and neuromuscular blocker was held. The patients had pyramidal signs. 2/3 of them, their toes were upgoing, they had brisk TRs, and even assumed ankle clonus. Now, when 1/3 were being discharged from the ICU to the wards, they were still not normal neurologically. They had inattention, disorientation, and, quote, poorly organized movements. Now, they did a host of different tests. Lumbar punctures were not done for concerns about the infection risk to those doing them. And the neural findings were non-specific, including not particularly enhancement. And the essence of it was a thought that these were neurological complications of prolonged ICU care in an older population. Now, then there have come out some reports from Italy and New York City, and this is probably important in that there are patients who don't have a lot of stroke risk factors and don't have initially COVID-19 typical symptoms, and then they're in the 30 to 50-year-old group, and they get stroke-like symptoms, and they often stay home, refusing to go to the hospital initially. So we are seeing some patients who are getting large vessels, ischemic strokes, without COVID-19 symptoms. Some of them have stroke risk factors, but others don't. And it may be reflecting COVID-19 infections, particularly when they're severe, can be pro-inflammatory and prothrombotic. Now, this is a study from the Netherlands that I think is very interesting. And basically, it was 184 COVID-19 patients with COVID-19 pneumonia seen over about a month in several hospitals in the Netherlands. And 76% were still in the ICU at the time this paper came out. Basically, what they found was and often these patients are hospitalized in the ICU, intubated 2 to 3 weeks. And the longer they stayed there, the more they saw, guess what? Thrombotic complications. Venous 27%, arterial 3%, 25% had pulmonary embolism. And they also had some catheter-related upper extremity thrombosis. 3 had arterial stroke. Nobody had DIC. What they did was that despite giving modest doses of thromboprophylaxis, 31% had thrombotic complications. And they said without evidence, but we've started to do this too, give Lovenox 40 milligrams twice a day, not just once a day, to these patients. Now, what are we seeing? We see that many of the significant neurologic symptoms and complications that we would be consulted about more often are happening in patients with severe COVID-19. What is going on with these patients? They have excessive inflammation, exaggerated immune responses, cytokine storm. They have ARDS, acute lung injury. They often, when they're in the ICU, become hypotensive, require vasopressors. They may have cardiomyopathies that develop, acute renal failure requiring dialysis. And basically, from a neurologic standpoint, they have prothrombotic and pro-inflammatory states. Now, this dreaded cytokine storm often begins day 7 of the hospitalization, and it increases the risk for neurologic symptoms. And as we know, some of the young ones who die often had a cytokine storm. And what we see is the markers of serum ferritin going up, cytopenias, ARDS, unremitting fever, and this elevated interleukin 6. And this is about this condition, which resembles this condition. It's a hyperinflammatory syndrome, fulminant hypercytokemia with multi-organ failure in adults. It occurs in about 3 to 4% of sepsis. It is most commonly triggered by viral. And then in the a recent retrospective study from again Wuhan, they confirmed that those patients who had cytokine storm often had a markedly elevated a ferritin level, an acute inflammatory marker, and elevated interleukin-6. And there's been some use of interleukin-6 inhibitors to try to treat this. Now, this is a case that has been reported of an acute necrotizing encephalopathy in a woman with COVID-19. This woman is an airline worker, and she presented with a 3-day history of cough, fever, and altered mental status. She was confused, lethargic, disoriented. They swabbed her nasal pharyngeal and came up positive for COVID-19. They did a CSF TEP, but it was traumatic, so you can't interpret that. It might have been, and they didn't even, they just said it was traumatic. They didn't even try to go further than that. And they gave her IVIG. They did not give her steroids. And this condition is most likely favored. It's not invasion of the brain, but rather that it's a reaction to the cytokine stores. And this is the neuroimaging, which showed hemorrhage indicated by the hypointensity, and I gave you these films. Now, from my take on this, and I begin to see this brewing in all these papers, this infodemic that we're having, so far the neurological complications of COVID-19 may only be indirect or secondary effects. Look at this. We know what these things can do. Hypoxic injury and hypotension, prothrombotic state, maladaptive immunological activation, cytokine storm, perhaps post-viral Guillain-Barré. Here's our big favorite, multi-organ failure with all its ramifications, including sepsis itself. And then some of our drugs might be adding to the picture in our efforts to treat this. How often does COVID-19 invade the CNS? Please let me explain what's going on here. There is considerable debate beginning in the recent literature. We know that SARS and MERS coronaviruses in mouse models in humans can invade the CNS and often does so through the olfactory epithelium. Although there can be alternative routes through the blood, through the blood-brain barrier, particularly if it's inflamed and it breaks down. And then this possibility of it actually entering the brain via vagal afferent pathways. This is in the SARS and MERS, the other two highly pathogenic coronaviruses. However, there is so far a paucity of confirmation of actual CNS invasion of COVID-19 as the cause of these symptoms for neurologic symptoms. Now, what do we know? There's this first case of meningoencephalitis that came from Japan, and they found in the CSF SARS. And this patient took a few days to get, as is often the case, there was some speculation that it takes several days for the virus to settle down in the lower part of the brain. I'll talk about that a little later. And he evolved and required intubation. He had multiple seizures at the beginning of his intubation, so late in the course of the disease. He had the lesions on his CT, and he had an LP that showed 12 monos and an elevated opening pressure. Then on his MRI, he had, they thought, some hyperintensity in the wall of the inferior lateral ventricle. I'm simply telling you. And they interpreted this MRI findings, right lateral ventriculitis and encephalitis, and then also some involvement of his mesial lobe and hippocampus. And he also had some sinusitis. Then this is a case from COVID-19 from Iran, of a young lady who had symptoms for about 5 days and then started having seizures 5 times every 8 hours. Her chest CT showed the focal ground glass opacities. She had a nasal swab, respiratory specimen that was positive for SARS. COVID-2, and then they gave her anticonvulsant medication, Keppra, and antiviral. A lumbar puncture was not done, and they just left it at that, and I think she recovered. Here, as you know, came some cases. This was a letter to the New England Journal of COVID-19 Guillain-Barré. We looked at this case. They say it's an uptick in Guillain-Barré that would be normally emitted to Bergamo and in Italy. They were positive for the virus. But you know, what's a difficult issue, and they developed maybe 5 to 10 days after the onset of COVID-19 symptoms. None of them had dysautonomia, and when the EMG findings, you know, might even be critical illness myopathy. So those are what are reported. Now, remember that the neurologic symptoms of SARS and MERS were quite different. They tended, as opposed to the quote early neurologic symptoms, SARS developed primarily the neurologic symptom of a peripheral neuropathy or myopathy with elevated CK 2 to 3 weeks after the infection. They thought, again, this might be post-viral, but they actually showed that they had widespread vasculitis in multiple organs, including striated muscle. In the closing moments, I just want to try to explain what's coming out of the literature, and that is that COVID-19 gets into the cells by using two co-receptors. Everybody knows ACE2, but there's this other one, TMPRSS2. Now, if you look at this YouTube website, it's a fancy CDC group investigating. What their comment is that ACE is not that, the percentage of ACE receptors is not that high in the brain compared to the lung, the kidney, the olfactory epithelium. The one cell type that has both of these in this study were oligodendrocytes, all right? And so they speculated, well, if they had a CNS infection and the two receptors were found, you would probably affect white matter. I don't know. Now, what is really worthwhile, and this is the last slide, is this paper, which is, you know, this study is really quite interesting. And that is this. From Perlman's laboratory, they did elegant research trying to see what is the pathology of SARS attacking the nervous system. And what they showed was that SARS causes neuronal death that is not apoptosis. So it doesn't mount the same inflammatory response. So they don't have encephalitis. Worse yet, the best way in this animal model that is transgenic for the human ACE was for the corona SARS virus to enter the brain through the olfactory bulb. But then they show in the paper how it spreads, and it spreads and ends up in the cardiorespiratory centers in the medulla. And there's been some reflection that the respiratory difficulties are made worse, the cardiac problems, by damage to the medulla. And there is minimal cellular infiltration in the brain, neuronal death without encephalitis, and then the brain does mount a interleukin 6 reaction. So I will bet that the problem here is that the coronavirus, the COVID-19, gets into the brain, it takes its sweet time to get there, and it may mimic the same thing as SARS, where it doesn't really make an encephalitis, but it causes an interleukin 6 reaction, it causes neuronal death, and worse yet, it may settle in the same area of the brain, the medulla, and there it contributes to the respiratory problems and perhaps the cardiac arrhythmias. So far, that's my take on it.
And that's all I have to say.